Right, good evening, everybody. We're just waiting on some more people to join us, and we will get started very, very soon. So, Leena, what time is it with you at the moment?
It is 8 o'clock in the
8
evening,
o'clock
New
in the
York time.
evening.
Yep,
Lovely.
yep.
It's 1 o'clock here in Ireland. So
Amazing.
it's almost the next day. It is the next day, actually. So it's great. It's great to have this conversation no matter where we are in the world, isn't it? It's fantastic that we can just link up
Absolutely.
and chat about endometriosis and pain and all the things that's around that, So we can see just
Absolutely.
some more people coming in here now, which is great. And I'm very conscious of people's time. So we'll just give it one more minute and then we will get started proper, if
That's
that's
great.
okay.
Thank you, Kathleen.
Perfect. And just as we have people joining here as well, like we should also mention that this is a fantastic opportunity for patients, provided by telehealth. I think it's a really, really good focus on endometriosis. It's something that we need so much more of. And it's fantastic to see the engagement. And it's given me certainly a great opportunity to speak to experts, which I absolutely love because I always learn something new in each session. And I think that's always really good. Because not only when we learn for ourselves, we can also take that knowledge back to other patients and to friends and family as well. So I always like that. I think that's really important.
Yeah, even from a provider perspective, I mean, I've found that to be true.
Yeah, it's great, isn't it? It's great that we have the tools to be able to do this. And for anybody who's new to the webinars, telehealth also have an app as well where you have expert-based information that's very factual. There's not the usual things that you'll get on the socials. It's peer-reviewed information, which again, as we know, is really important in this day and age of misinformation. So I think we have a few more attendees in here now. So Dr. Mathew, we'll get started. But just first of all, I just want to again welcome everybody to this session. So it's endometriosis in focus, advanced treatments for managing pain, something we all know really well with endometriosis. And the content of this live Q&A session, this webinar, is really an educational purpose only. So we're not intending this to be a substitute for your normal professional healthcare advice or your normal appointments that you'd have with your own physician. So it doesn't constitute medical advice or care in any way and doesn't confer a relationship between, any of the healthcare professionals on the webinars and the patient themselves. So any concerns that you have really should be discussed with your own personal physician or healthcare provider. But again, these sessions are a great way of finding that information to take back to your healthcare professional. So Dr. Leena Mathew, Professor of Anesthesiology and Program Director for Pain Medicine at the Fellowship of Columbia University Irvine Medical Center. Thank you so much for joining me this evening. I am not going to even attempt to summarize your qualifications and your interests. I think you're best to do that. Do you want to share with us your interests and your specialty in pain?
Absolutely. Thank you so much, Kathleen. So I've been doing pain medicine at Columbia for over 25 years at this point. And so I've had skin in this game for a very, very long time. And, it's about time that we started talking about women and chronic pain because it is this completely missed topic, right? So women tend to be completely dismissed when they get in there and complain about pain. I mean, it's well known. So, I couldn't be more excited to be here today. Women's health is a particular interest of mine, pelvic pain, just because of its complexity and because of the lack of treatments in general and the lack of providers specializing in pelvic pain in women of all age groups. So that's where my special interest lies, in addition to like a whole bunch of other interests that I have in the sphere of pain management. But I do want to say that the conversations that we are having today, these are not, this is not really medical advice per se. I mean, you really have to speak with your physician and understand what your particular concerns are and how they apply to you. The views that I'm expressing are not the views of Columbia University either. I have been working at Columbia University, and I've been a professor there in pain medicine and anesthesiology. And I work with, academic like fellows who are specializing in the field of pain management. So it's a real privilege for me to be here and to talk about this particular topic. So thank you everyone for joining us. And, it is just it's incredible that 2024 is actually the global year for sex and gender disparities in pain. And this was announced by the International Association for the Study of Pain. So, it's appropriate that we're having this conversation right now. So, so let's launch right into it. And I'm going to try and address endometriosis and pain, but also address several of the questions that were entered. So I do have these questions. There are some questions that overlap with each other, but I would encourage the participants to also include their questions in the chat box, and I can go through them as the conversation progresses. So just in terms of introducing the topic itself, we're talking about pelvic pain, especially chronic pelvic pain. And in women, this presents as an incredibly prevalent and complex condition, right? And has a lot of implication when it comes to health, when it comes to quality of life, but also like socioeconomic costs. The burden is more than just physical discomfort and physical burden. And it needs very carefully coordinated care. It needs collaboration with the patient, but also with the whole team that's taking care of a patient, because of just how multifaceted pain is in its presentation and how it's influenced not just by the physicality of the disease, but also by so many psychological factors and social factors. And, it's mind-boggling to me that 2 in 10 women will experience chronic pelvic pain. That's 20% just in the general population. And 40% of women will experience pelvic pain at some point in their life. And women, as I mentioned before, tend to be dismissed more than their male counterparts when they're seeking medical attention, especially when it comes to complex conditions like pelvic pain. Right. So pelvic pain, especially because of endometriosis and adenomyosis, which is the target of today's conversation, tends to be more common in women between 18 to 50 years old. And by that definition is more likely in that working age group as well. So hence that widespread consequences on socioeconomic front as well, with regards to burdens that go beyond just personal discomfort. But it affects everything, affects quality of life, leads to emotional distress, can lead to relationship problems and decreased physical functioning as well. What really concerns me when I talk to patients is really the sense of loss of agency. There is this deep, profound sense of hopelessness, despair, but a loss of agency that comes from living in chronic pain. A big part of this understanding of chronic pain stems from first understanding that chronic pain is a disease. When you have an acute injury, when something happens suddenly, when there's a disease process, you may have acute pain, which actually confers some evolutionary benefit. Like if you touch a hot stove, you'll learn from the pain associated with it never to touch it again, right? To be careful the next time. But with chronic pain, there's no evolutionary benefit to it. It's just a disease state. There's nothing good about it. And the problem with chronic pain is that it can continue even when there is no attributable cause. Mm-hmm. And that's the hardest part for our patients to grasp, because there is that physical component of pain, but what becomes even more distressing in that long term, when you live with pain in and out, like day after day, then there is a distress associated with it, right? And there are several factors that patients may understand, these are the factors that sort of increase the risk of chronic pelvic pain. So if you know that there are certain factors associated with it, then you could be more attentive to its development and maybe even like stop its development. So, gynecological conditions like endometriosis, adenomyosis, that provokes the chronic pain as a disease, right? And in addition to that, there could be other conditions like, psychosocial factors, like just having high stress, anxiety, depression. These are all significant risk factors. And to diagnose this chronic pelvic pain stemming from endometriosis, you need this comprehensive approach. Talk to the doctors, they get medical history, examine you, do various diagnostic testing to understand what underlying conditions you may have. But the treatment, and this is the first question really, is like, what are the treatments of pain and endometriosis? And, I have to say that effective management of endometriosis, I wish I could tell all the listeners that there is this one thing that you could do and it would take your pain away. But we're all so distinctly different as individuals. So there isn't a one magic thing that takes the pain away equally for all people. So the only thing that's been known to be effective in the treatment of endometriosis related pain is that you need a personalized multimodal approach that addresses the physical component, but also the psychological component of the condition. And I find that in talking to my patients, as I'm building trust with my patients, that often there is a sense of, but my pain is real, right? It's not in my head. And there is this immediate sort of like, it's not a psychological issue. And if we didn't have a brain, we wouldn't feel pain. We feel pain because we have a brain that processes this information. So it's really important to understand that piece and to be realistic with the expectations for treatment, right? And it's important to desire complete freedom from pain and to want that complete freedom occurs immediately. But it's still important to have this realistic expectation in discussion with all of your doctors about what symptoms can you expect to resolve completely and what can persist and what steps could be taken. And knowing some of those steps in advance, even before you go in for surgery, endometriosis surgery, knowing what steps are ahead, what lies ahead, can help you as a patient establish sort of a roadmap of strategies, roadmap of treatment strategies, and a timeline that may be realistic for you. Right? So surgical treatments are well established, but there's pharmacological treatments. And these are treatments like hormonal therapies when indicated. And, I'm not going to discuss hormonal treatments because it's a little bit outside of the scope of my expertise. And I would suggest that my patients discuss that with their gynecology provider or other healthcare providers that are involved in their care. But hormonal therapies definitely have a role because they can improve the hormonal environment and then thereby decrease sort of the size of the lesions or regulate the menstrual cycle if there's a cyclicity associated with the menstrual cycle and endometrial pain. So that's a conversation that needs to be had. And, patients select, and patients decide, I don't want to be on hormonal treatment. There is a fear associated with it. So that conversation has to happen, right? Because that fear has to be addressed. And you may be a great candidate for hormonal treatment, and it's possible you're not a great candidate for hormonal treatment. But the conversation just means you're flicking the light switch on and you're just gathering information. You're just understanding what's the territory look like for you. But there's several non-hormonal treatments as well. So we'll talk a little bit about that because that's come up repeatedly in some of the questions. But I want to say that all of these treatments that are out there, they do offer improved outcomes for women who are suffering from chronic pelvic pain. So surgery is, one of the most established treatments there is, and there's different kinds of surgical therapies, which I know there are different physicians on this webinar panel. They've brought that up and they've discussed this. But one of the questions that has come up multiple times actually now is why do people have pain even after surgery, and how do you manage this pain? Because you're going in to get endometriosis surgery with sort of an expectation that your pain should improve. But let me tell you, 25 years as a pain doc, and majority of my patients who come in are continuing to experience pain even after endometriosis surgery. Now, that's why they're seeking help. This doesn't mean that majority of the patients who have endometriosis surgery continue to have pain, but there is a subset of patients, and those patients do come up and seek attention with pain physicians. So the way I can answer that the best by saying, first and foremost, you need to address the cause and the etiology of the pain, right? And it's just as important as doing that is to address the pain through multiple mechanisms, right? So just because you're trying to identify the diagnosis shouldn't stop you from treating the pain. So the treatment of pain through multiple mechanisms can start even before surgery. It's never too early to engage with the pain physician to start discussing this. And in doing so, you can maybe decrease the overall perception of pain, but also avoid its chronification. So, I'll tell patients that whatever it takes to move the needle forward, right? Even if it's incrementally, as long as it's moving in the right direction. And if you could decrease the chronification, hopefully like in a couple of years, when you look back, you can look back and say, oh, you know what, that was really tough, like 2 months of my life or 2 years of my life. But hopefully in the spectrum of your life, it's not a lifelong disease and you're not living with chronic pain for your life. Now, in the immediate aftermath of surgery, it's important to be treated with, all of the supportive measures. So, from Tylenol to anti-inflammatory medicines, muscle relaxants, maybe nerve blocks done before or after surgery, and opioids. Opioids actually have a role in that immediate treatment after surgery when patients have acute pain, because, there's injury and inflammation, and that's inflicted by surgery. So in that, there's evidence that in the first 3 to 5 days of surgery, it's generally speaking, great. Opioids are great for pain management. And if there's like an unanticipated increase in pain, or if the pain isn't like improving significantly, then it needs to be looked at. Like, are there other sources of pain? And there has to be this prioritization of getting patients off of opioids as well. And this continued experience of chronic pain even after surgery, that's really the best reflection of the complexity of chronic pelvic pain, if that makes sense. It's the hardest concept to grasp because people are looking for a cure. But unfortunately, with chronic pain, there isn't this indication of active biological disease. But that implication, or even this idea of threat or harm, it can maintain the perception or this image or memory of pain that's imprinted in the brain. So even when healing occurs and the disease process is eradicated, that picture can continue in the brain. And so even the perception of that picture is sufficient to maintain the sense of being in distress and having pain. It's a very real experience. It's not an imagined experience. And I really try to make that distinction with the patients. Yes, we experience pain because it's ultimately felt in our brain. And with or without disease, it's a very real experience. But I think it's important for patients to grasp that, and for providers to grasp that, like, all teammates, like the other physicians, to understand that. So, and the reason this is because that physical component of pain has to be translated through a very unique individual lens. And that includes your genetics, your environment, cultural factors, expectations, your experiences, but also your behaviors, like, how we tend to respond to discomfort. That starts to play a role in how we respond to the extreme discomfort associated with being in pain. So there's that pain that's associated with physical distress, but that gets magnified by our emotional distress and the suffering, and that loops into magnifying that physical pain even more. So if there's heightened stress around this, and then there's poor sleep habits associated with this, that will also escalate the perception of pain. So the reason I bring that up is, this will hopefully allow you to understand that the experience of pain is so much more than the disease is cured, and here's the pill, or here's the block, and you should be all better. Because there's so many layers by which we see pain. So there's like multiple lenses. So each patient's experience of endometriosis, and thereby its treatment of pain, has to be unique, right? It's going to be influenced by your genetics, it's going to be influenced by your biology, and it's going to be influenced by your psyche. And so that variability means that patients will not respond to surgery. Some patients will not respond as effectively to surgery as other patients will. And then the same treatment may not work across the board for everybody. So there isn't this one treatment, right? So it has to start with understanding this whole principle of pain memory, and how do we erase that pain memory using whatever resources we have available to us, right? And sometimes those resources are dictated by insurance, finances, and so on. But comprehensive pain management includes medications, almost always physical therapy and psychological counseling, ongoing monitoring and treatment of coexisting conditions to make sure that other conditions, so we're not missing the forest for the tree, right? So it's not that your pelvic pain is coming from your back, right? Now, because everyone's been focused on your pelvic pain, they're completely missing that this may be stemming from another source. It could be muscles in your hip. It could be ligaments in your hip or your pelvis. So it could be another source of pain. So you need someone who is an expert and who has looked at this before and seen this before to really identify the source of your pain. So, as you're treating patients with medications, physical therapy, and psychological counseling, it's also important to discuss like the other modalities that are available. And interventional pain doctors do just that. They may use nerve blocks to diagnose where the pain is stemming from, because that allows them to predicate what the next step is. Because there's a whole host of nerves that supply different organs, different muscles, different ligaments at different levels, near the spinal cord, adjacent to the spinal cord, within the pelvic floor itself, or within the muscles itself. And by targeting different components, you rule out each of these components as a source of pain. Or it's possible there are multiple factors involved, and doing nerve block A takes away 10-20% of pain. Doing nerve block B takes away 10-20% of your pain. And you may need all of these in concert to get you to a point that this is reasonable for you. And it gets you to the point of like, okay, every time you do something that helps with the pain, even if it's 5%, 10%, 20%, it's erasing components for you. It's erasing that pain architecture, that pain memory for you. So, I'm really trying to just, make this like as simplistic as possible. And it's also important to remember, like, hey, if pain extends beyond surgery for several years, you may need different, it is understandable to get frustrated. The process is frustrating. So you may require more examinations, more scans, more diagnostic injections. Patience is really key, because even if no cause is identified, it doesn't mean that your symptoms are imagined, right? And I think understanding that piece and having that foundation is really important. It's critical because it helps you then do the steps that you need to do to treat the pain. I do see some questions popping up. Maybe I'll take a look at that.
We'll have a look. Just, what you're saying there is so important, because as people who live with endometriosis, we've often been misdiagnosed or don't have a diagnosis for a long period of time. So that pain has been building up for a considerable time, even before surgery. And I imagine that feeds into that chronic pain cycle as well. It's such a complex condition. And then when you add in all the other factors as well too, you can see why a specialist opinion and a specialist appointment is so important, because as patients, we tend to put everything down to our endometriosis. Like if it rains, it's because of our endometriosis. So we need somebody to tease out those pieces, don't we? And work with us on that,
Absolutely. Absolutely. And so I'm seeing this question here. It says, discuss the complexities of treating PMDD and endometriosis combination. I'm not sure what PMDD is referencing. So if you could just type that into the chat box, that would be helpful.
I think they're referencing premenstrual dysphoric disorder.
Yeah,
so
I just did not want to assume that. Yeah.
Let me see. We'll check the chat as well, just to be sure. But yeah, if the person who's answered that wants to just clarify that for us, that'd be perfect as well.
Yeah, just don't want to make an assumption when it comes to acronyms. But you're absolutely right. I mean, okay, so PMDD, yeah. So the complexity of treating PMDD and endometriosis is, I think I alluded to this. Our psychological makeup has a lot to do with how we perceive pain. Several of the chemicals that your body needs to maintain your mood, for example, serotonin or norepinephrine, you need those at a certain adequate level to feel a certain way, to feel whole, to feel well, to feel not depressed, not anxious, right? But those same exact neurochemicals are what are needed to stop painful input from being processed in the brain. So they're also the same mood uplifting chemicals are the same chemicals that suppress pain information from traveling to the brain. Does that make sense? Which is why when you have anxiety, which is why when you have pain, when you have depression, it amplifies your experience of pain. So, so antidepressants, pain doctors use antidepressants all the time, right? And we don't use the antidepressants so much to treat the mood and the depression associated with the pain, because the two can coexist. right? But one can certainly make the other worse. But we know even independent of having a clinical depression, you can use an antidepressant and find that it actually does alleviate some of your pain. And the way it does that is by adequately sort of producing enough chemicals in your body that you need to suppress that pain information from getting up. And you're absolutely right. I mean, the question here, has a second part which says it seems solutions for one complicate the other. And you're absolutely right about that. And this is why there isn't that magic, go get this done, because it has to be individualized, right? So when my patients talk to me, I may say to them, listen, I wish I could use an antidepressant for you, but here's the 10 reasons why I don't think antidepressants would be the right combination for you, because it may interact with ABC drugs, or it may give you side effects that you're not willing to tolerate, right? Now, side effects happen with all medications, and it's up to the patient, and it's up for you to discuss that and discuss whether or not the side effects are tolerable for you. And by that, I mean certain side effects are tolerable side effects for some people, like a dry mouth. And I may tell you, okay, is that intolerable for you? Is it really impeding from your quality of life, right? Is that okay? But if if you suffer from urinary retention, and being on an antidepressant gives you severe urinary retention, and you're like just now consumed by the sense of a full bladder, it's not a tolerable side effect for you. Or if it's a medication that's keeping you awake through the night or making you fall asleep in the morning, when you should be awake and working, maybe those are not the right medicines for you. So you do have to have detailed discussions about the risks and the benefits of each of these modalities with your physician. And, I know it's frustrating and I really try to keep like an hour and a half during my visits with my patients so that we have time to talk through all of these options. And sometimes one visit isn't enough, and you may have to just make another visit to get your questions answered in terms of, is this appropriate or not? But there's also this piece where the side effects that occur in one may not occur for you. So there has to be this openness to trying things that haven't been tried, because, you may not have any of these side effects. Because if a side effect exists, it's been listed, right? So, and every side effect known to man can be ascribed to every medication. But does that really apply to you? We don't know, right? So that's a discussion between you and your physician. So
And
there's a second question.
Can I just
Go
ask
ahead,
before we
Kathleen.
go to that second question, how long would you recommend somebody would try a particular medication? Would you have like a cutoff? Do you say to your patient, maybe try it for 6 weeks or try it for 3 weeks or 6 months? Is there a guideline for that?
Absolutely. And Kathleen, I'm so glad you bring that up, because this is a super common thing that comes up. I have patients who often try a medication and then they come back and say, it didn't work, so we stopped taking it. When it comes to chronic pain, none of these medicines, I see reference to gabapentin. Gabapentin is an anticonvulsant. It's an anti-seizure medicine, and it's a possible treatment option, right? Now, I mentioned antidepressants, possible treatment option. So a lot of these medications don't have fixed doses at which you individually will respond, right? So, but if you were to get the highest the maximum possible dose, you probably would have side effects. So what your doctor may opt to do is start you low and go slow, right? So we're trying to identify, are you going to have side effects? Because my priority with my patients is, hey, patience is going to be needed. And we're going to just make sure that you're able to tolerate this medicine without side effects. Because if I know you will tolerate the low doses, then I can slowly amp up the dosing and get you to higher doses. And at those higher doses, you'll probably tolerate it better. And or have confidence that you'll tolerate it, because now you've tolerated those lower doses. But at those sort of maximal doses, or what we consider therapeutic doses, you need to be on therapeutic doses for 6 to 8 weeks to even know if this medicine's working for you. So that's what we consider an appropriate therapeutic trial. So, yeah, don't be disheartened. Gabapentin, for example, is an anticonvulsant, and your physician may think it's a great option for you because it treats nerve pain, because a lot of pelvic pain could be ascribed to sort of a nerve-related pain as well. And just like anticonvulsants, which is anti-seizure medicines, calms down the firing of impulses in a brain with seizures, it can actually calm down the firing, excessive firing of information in these pain nerves. So it stops this onslaught of impulses from the pelvis to the brain and making this brain hypersensitive. So it stops that onslaught. And so I would not want to try gabapentin at maximum doses. But as your doctor, your physician will know that at a certain dose, what we consider an appropriate dose, and beyond that, there's no value in increasing it. But I probably would not start any patient at 900 milligrams of gabapentin 3 times a day. But I know that I can safely escalate to that dose if you're able to tolerate maybe starting with 100 milligrams at night. And then every week we're going up slowly. So it needs patience. And that would be, and that's the way we would sort of like titrate these medications to effect for an appropriate length of time. And then at that dose, if it doesn't work, yes, super frustrating. But then you can say it does not work. You've given it a try.
Yeah.
So
And
yeah, so that's really key.
Is there any risk then, like we know as patients, we tend to get very frustrated and sometimes might just stop taking a medication and one, not feed back to the clinician. And the other thing we tend to do is just stop at cold turkey. And I know with some of the agents like gabapentin or maybe pregabalin, that this could be quite harmful. Should we taper down and should we always have that discussion with their clinician before we would do that?
Yeah, well, you should certainly have a discussion with the physicians. Now, at certain doses, it's reasonable. You could just go cold turkey. It's not going to give you a withdrawal. It's completely safe. But then at certain high doses, it may be reasonable to start going down on the dose. I tell patients not that I'm concerned about withdrawal, because it's rare to have withdrawal with these medications. With gabapentin, with antidepressants, you certainly need to go down slowly because you could have a little bit of a withdrawal from it. But gabapentin tends to be fairly safe, well tolerated in most people. Now, if you had a seizure disorder as well, it could precipitate seizures if you were to suddenly cold turkey stop it. But it's super safe otherwise, right? So you could cold turkey. It may not be comfortable. The reason I ask patients to taper down slowly is because, let's say you're at 900 milligrams, you go down to 800, you go down to 700, and then at 700, you realize, ooh, my pain just feels worse. And you may realize that it's been doing something. So in the course of that taper, you may realize that it's doing something for you that's been helping you. And you may decide that, okay, you know what, at 900, not great efficacy, but at 700 or 600, this is pretty good because if I go down below 600, it's not helping. It's getting worse, so, and going above it, it's not helping further. So maybe 600 is the optimal dose for now. And while you're on it, you could consider other things as well.
Definitely about finding that perfect fit, isn't it? And again, keeping very good detailed notes, I think, as you go along, to help sort of feedback and appointments, but that's really good. And it's very encouraging to see that, on the taper up as well as the taper down, we can learn from that and we can maybe find that sort of that very nice sweet spot where things start to work for us,
Absolutely. Absolutely. And so I see another question here about trigger point injections. Have they been proven helpful with endometriosis pain? So yes. So, short answer is yes. But is it going to be helpful for you? That's the question that needs to be determined, right? So the short answer for all of these treatments that I've mentioned, they're all helpful, right? But what combination of these treatments is going to help you? That's the piece to understand. So with any kind of pelvic lesion, with any kind of injury, there's a fair amount of muscle spasm that happens, right? Because muscles become more tense and they go into spasm because they're trying to protect that area, right? They're trying to protect that area. So it's just like we clench our jaw, we can clench our shoulder muscles, our neck muscles, like we have tension in these areas. Some of us, like our weak spots, are our pelvis, right? And those muscles you're not even aware of. You're not aware of the lack of tone there, and you're not aware of the not even perceptible spasm there or tension there, which is where, I almost mandate that all my patients get pelvic floor physical therapy, that they engage with pelvic floor physical therapy and learn techniques of mindfulness and stress reduction that also includes sort of biofeedback to the pelvic floor so that they can learn how to relax the pelvic floor, strengthen the pelvic floor. And with a good physician, with an interventionalist that has experience, talk to the doctor who's planning on doing trigger points for you and understand how you stand to benefit from it. So with any injection, I would say, it may help substantially, but on the flip side, it may not help at all, right? And you have to go in willing to take the chance that this may not help, but really hoping that it does. In most people, when there is pelvic floor spasm and tension associated with the endometriosis, then yes, trigger point injections can be extremely helpful. And experts in pain management, they actually know how to use an ultrasound to identify the muscles of your pelvic floor and inject quite safely into the pelvic floor. So trigger point injections can be done with local anesthetics just to kind of relax the muscles there. But also, if you're a good candidate for it, Botox may be something that could be injected into the pelvic floor and allow for some pain relief. And Botox and these trigger point injections could be done sequentially. So you may be somebody who needs it 3 times a year, 4 times a year, maybe, or every 3 months. Everyone's different. You get that first injection, you understand how you respond to it, and maybe what steps need to be taken.
That's fantastic to even have that option as well too, isn't it? That it's not just, you're not just relying on either muscle relaxants or a lidocaine, like that Botox is an option for that. Yeah, it really is. Yeah, no, it's fantastic to see that.
And then I see part of this question, I'm sorry that I split this question, but I think I answered the component about, is gabapentin an example of one that can treat nerve pain? Absolutely. And it is a possible treatment option for endometriosis. Yes. Part of that question is, could you explain what nerve blocks are? Yes. So nerve blocks are, what we do is we try to identify what are the nerves, because pain essentially is this final sensation perception that's occurring in the brain, but it's messaging that's carried through electrical wiring, right, in the body from the pelvis. It's going to the brain, right? So there's nerves that are the electric wires per se. So we could block these nerves by injecting medications like local anesthetic, very similar to what a dentist does when he's doing dental work. You may get some local anesthetic, Novocaine, injected in your gums to numb up the area. Or I'm sure you've gotten local anesthetic for minor procedures. So nerve blocks basically try to block the nerves by injecting numbing medication along the nerves that supply different parts of the pelvis or along the spinal cord. And from that, we get information. Is it nerve A, nerve B, nerve C, nerve D, or none of them that's causing the pain? And now if it's a particular nerve, the first time a nerve block is done, it's really a diagnostic injection, which means it gives us information. It's like flipping the light switch on and saying, wow, okay, you've got this pelvic pain. We blocked your pudendal nerves. And the pain went from being at a 10 out of 10 to being 2 out of 10. It's spectacular, right? So then the next step is us understanding, how long did that last for you? Did the pain come back the same day, which would not be surprising? Or did you actually get some kind of an erasing of pain in your brain where that effect of that block lasted for 2 months, right? So could we just repeat that every 2 months? Certainly, that's an option. Right? And then every time we go in there and we erase that memory of pain, it gets better and better. So you may go from needing a set of treatments or these nerve blocks every 2 weeks to every 2 months to every 2 years to never, right? So there may be a process. It's important to identify where in that process do you fall. So which nerves need to be blocked are something that your doctor will talk to you about, because you may go in there saying, I want this nerve block done because my friend ABC had a certain block and it took away her pain. Well, and that person, that particular nerve may have been implicated, but that may not be true for you. And if that's not true for you, the doctor needs to do these diagnostic blocks to identify. So they may start from the lowest hanging fruit, by which I mean where you would get the most answers for the least side effects, right? So it may start with the trigger point injection, just blocking the muscles, and then it may start with doing a pudendal nerve block or a ganglion impart, and then there's like different levels of blockade that can be done. And these blocks have been around for decades. I've been in practice for 25 years, and I was taught this by folks who had been doing it for 20, 25 years. So I know it's been there for like at least 50 years. I mean, these blocks have existed for a long time. And now with imaging, and we use X-ray monitoring to identify the landmarks and do these blocks quite safely, ultrasound. So there's imaging associated with how we do these blocks to increase our margin of, delivering an appropriate block. And so if you don't respond to a well done pudendal block, it's probably not pain that's coming through the pudendal nerve.
Yeah. And are there any risks or side effects? Like, could people react maybe to something like in any of those injections, or, could it cause like any muscle inflammation? Is there anything that we would need to be sort of wary of, or that we need to report back?
Yeah, I mean, you'll have a conversation with your doctor in terms of all the particular side effects. So, there could be, I like to lump side effects into two different categories. One is like medication related side effects. So you could have an allergic response to the medication that's being injected. Now, that's not very common with lidocaine, which is the usual local anesthetic. Now, so allergies, definitely, it's possible you could have it, right? The second piece is where the needle is, right? So if the needle's not exactly where it's supposed to be, then yes, there could be complications from that. But also how the needle's placed, right? So is it done sterilely, which means, with very careful attention to infection control? Is it done by people like, if somebody else, I would have complete confidence doing these blocks because I've been doing this for several years. But I may not have the same confidence in someone else who doesn't have quite the training, quite the expertise, quite the understanding of the anatomy to do these blocks. So it also depends upon who's doing the blocks, right? And how safe. There could always be side effects, but complications are not side effects. It's a little bit more. So infection is a complication. Can complications occur? Yes. So infection, bleeding, because anytime a needle is going through skin and tissues, there's a risk of bleeding, bruising. When there's bruising and bleeding, there could be a short-term worsening of pain. You're working in and around nerves. So you could definitely have like nerve injury, nerve trauma. Now, these are minimized because we use visualization, because we have so many methods to visualize where we're placing the needle that it can be done quite safely. So it's not like 50 years ago or 20 years ago how we did these blocks. When I started doing these injections, we did a lot of these injections just by feel, by understanding that this is where the nerve lies and having sort of an algorithm and a formula to do these. But now you can actually see these structures. So it adds like multiple layers of safety, but they're not risk-free.
Again, it's balancing the risk with reward, isn't it? And, that's that very individual conversation about finding that right treatment plan. Again, it's so important. And I just want to ask you, in terms of, we're bombarded with advertisements and products all over the place that promise us pain-free lives. And
Sure.
now that we've heard the understanding of chronic pain, and it's like that signal that's constantly there, like, and it might take a while for that to break. Is there anything like that we can use like at home over the counter, or, things maybe like acupuncture or TENS? Do they help with the chronic pain, or are they more for an acute pain?
No, they're definitely for chronic pain. Anything that's used for management is for chronic pain, right?
Right.
So even over-the-counter topical agents, right? So even just the application of like an icy hot lidocaine,
Yeah.
it just scrambles the messaging to the brain. So you mentioned a TENS unit. I'm a big fan of the TENS unit. Now, if you think about like elementally, even as kids, right? You bump your shoulder, you bump your elbow somewhere, and the first instinct we have is to rub our elbow. If your head hurts, you kind of do this. You massage your temples, right? So we have it's built into our system, and what we're doing in that moment is tense, because what we're really doing is trying to scramble the message. It hurts, and the brain is not it's a supercomputer, but it can only process so much information at the same time. So if you think about railroad tracks coming to the station, only one track can get to the station at one time. So if there's pain fibers along one track, and there is vibration and pressure and other sensation traveling along the same, adjacent to the same pain fibers, then I could scramble and I could stop, because pain is like small fibers. You could stop it You could stop it by sending some big information down that path, down that track. So I could send like light touch, massage, vibration, which is why rubbing the area of pain offers some relief, because in that moment you can't process the pain. I hope that's that's simple enough. So a TENS unit is something that's available over the counter. You can get its pocket size, it's portable. And it comes with some electrodes with instructions, and it's got some dials. You take the stickers or electrodes and you've got to play with the placement, right? So not like placing it once and saying it doesn't work. So you got to play with this with the placement. You got to play with the settings, and you just start dialing up on these settings until you start to feel like a creepy crawly sensation or a vibration or a thumping in the area where you have pain. So you've got to keep adjusting the stickers to sort of cover the area of pain, not directly on the area of pain, but it's sort of like covering the area. So that whole area is encompassed, like it's just covered by this alternate sensation. And that just scrambles this message to the brain. And you could use a TENS unit a few times a day. You could, if our patients will tell me that gardening makes it worse, right? Because they're like doing physical activity, they're bending over, they're in these weird positions. And I'll tell them, use it 45 minutes before you garden, right? Take it to school with you, right? So you could hide the unit in your pocket and the stickers are in place, and you could just take it out of your pocket, adjust the stickers, adjust the dial settings and get some pain relief. It may not take away the pain completely, but it may give you profound pain relief. So a TENS is it's a fabulous technique, and they've taken the concept of TENS many steps forward by doing things that our patients may have heard about, and it's things like spinal cord stimulation. These techniques of neuromodulation, which is like placing a little electrode right up against the spinal cord so that you can actually stimulate those fibers and scramble the messaging even closer. And so there's different techniques of neuromodulation. And when you talk to the pain docs, they can discuss whether that is a form of intervention that you may be a candidate for. So I think it's really important to have that conversation and get some advice on that.
It's fascinating when you start thinking that the nerves are carrying all these signals, and really what we're trying to do is sort of outsmart them a little bit, isn't it? And try and confuse them. But certainly I live by my TENS now, and acupuncture is a real point for me as well too. So, and I think it's one of your favorites. Give us a wee overview on how acupuncture is going to help with pain as well.
Acupuncture, I love acupuncture. I got special training in acupuncture because I just saw how much it can do for a patient. This is something that's existed for 5,000 years, right? And so, yes, there isn't a whole lot of great reviews and literature to support it, but I've yet to meet a patient who's had acupuncture. In 25 years, I've had complaints about all kinds of treatments, but I've never had patients complain about acupuncture. So I do know that it's one treatment that has no side effects associated outside of like minor irritation, maybe where the needles, these are tiny, tiny needles. With a good acupuncturist, you should be able to find reasonable pain relief, but at least a method of stress reduction. It's not just the pain, right? It's muscle relaxation, stress reduction, improving sleep, decreasing anxiety. All of those components could be addressed with the addition of acupuncture. So I have patients that come in, they get, 8 weeks of like a session of acupuncture with me. They see my pain psychologist who specifically works with them on the psychology piece of pain to understand how to cope better with it, to build resiliency around it, to improve their perception of what they're going through, to do some cognitive work, to do some cognitive restructuring, to reframe things, to stop allowing pain from taking control. So these are sort of the non-hormonal, non-medication, non-harmful methods that they could employ with me, right? And during these sessions, it gives them time with me so that we can have conversations as well, right? Which is it allows for that therapeutic interaction. So acupuncture has they've looked at studies looking at acupuncture, and they've put patients side by side and run them through a scanner to see what areas of the brain are lighting up. And what they've noticed is that when acupuncture is being administered, or even immediately after acupuncture, the same areas of the brain light up, as would light up after getting a dose of morphine. But what's
That's
even more
amazing.
interesting is the drug naloxone or Narcan is used to reverse the effects of morphine. If you were to give Narcan to a person who had just gotten acupuncture, it would reverse the pain relief associated with it, which is just,
Okay.
and which is one of those incredible things as well. And there's so much research to support it, but it's difficult to do great research with acupuncture. If we're, and I think it's outside of the scope of this conversation, getting into the weeds about that. But yes, definitely consider all those methods and techniques that may offer you relief and bring some ability to manage your symptoms better. So if it doesn't hurt you, definitely try it. If it's not going to cause excessive stress and burden, then try it. But if you have to travel like 2 hours a day to go to your acupuncturist and pay out of pocket, and it's labor intensive and not, if it's adding to your allostatic stress load, then maybe it's not the treatment for you. Just make sure it works with your life and it works with what you're looking for.
That's
So
it.
Kathleen, I see a question here about Visane.
Yes, see
Does
that in the bottom.
Visane, yeah. So this is outside of the scope of my expertise, but it is used in the treatment of endometriosis. And it acts like a synthetic hormone, like progestin. So it mimics the effects of the natural hormone, and it may help decrease the growth of endometrial tissue. And by doing so, it may help with the pain. But along the lines of what we've been talking, you may have like all of your endometrial tissues removed, and you may still continue to have pain. So yes, it may help. It may. This is where clarity needs to be in terms of what is the expectation. If your expectation is that this will help with the endometrial lesions, sure. But if the question is, is it going to help with the pain associated with the endometrial lesions, then it becomes a maybe. Because again, that pain has so many different elements. Because if that picture of pain is already there in your brain, you got to work on all of those elements to even allow maybe it is doing something for you. But to really get that full efficacy, you may have to still employ all of these other modalities and methods to get some results.
Absolutely. And I think we've learned this evening that, our pain is quite complex. It's got so many factors feeding into it. There's so many things that are in our control and beyond our control. And I think too that, it's like the pieces of the jigsaw, isn't it? We have to take all those pieces to put together a good treatment plan for ourselves, and not to be afraid to be sort of citizen scientists. We need to experiment, work with our doctors to sort of get those therapies, document our journey with it and feedback. And then if it doesn't work, we'll try something else. And you've given us some fantastic options for pain management, and a fantastic insight as to how chronic pain actually works as well. So thank you so much for that. Are there any other points that you want to add before we pass the session back just to our participants for the survey?
Yeah, I'm good if the participants are good.
Yeah.
There's one point I just wanted to make because it did come up on one of the questions, and I don't think I mentioned, are there non-opioid methods to treat pain? And so that
Yes.
brings us back to the same, we're trying to stay away from opioids as much as possible, because I'd like for all of our patients to understand that, it's not about this like legalistic, don't be on opioids. Opioids are terrible. Opioids have a role in the acute management of pain, certainly. But while they're great short term, being on them long term actually changes your perception. It changes your brain architecture and has like a whole host of like side effects. And ultimately, it actually makes you so much more sensitive to experiencing pain that it's really not good for you. So I don't like, and they've done this in mice experiments. They've like replicated this in human experiments, that it actually sensitizes you to the experience of pain. So opioids in the law, it's too much of a good thing, So yes, when you had surgery and you got it, it was great, but now get rid of it. You don't need to be on it, So really, when it comes to being in a non-cancerous pain state, there is no benefit. There's no utility to being on chronic opioids. So really, really dialogue with your doctors to seek out those measures of of non-opioid methods, and discuss like natural methods too. You know, if you have access to that, like herbs and supplements, you know, there are several of them that have been associated